Yep.
Okay. Well, thank you so much for, oh, you can see it?
You'll have to get it yourself. I'm in the middle of something.
Yeah,
Okay.
I can see the main screen and the definitions off to the side.
Oh, you can see that too.
I have to go pee really bad.
Michelle, can you put yourself on mute, please?
Sorry. Great. Lovely.
I can do it. I can do it. I got you. You're done.
I apologize. Is that better? Can you see
Yep.
that little bit? Okay.
Perfect.
All right. So sorry about that. Always technology difficulties, but thank you so much for allowing me to share some information with you all tonight. I'm very excited to be here. This is definitely something that um, means a lot to me to be able to share early intervention strategies and to be able to connect with other people, especially across our nation. I am Tiffani. I am an early interventionist, and I do also work in as an inclusion specialist for our agency. I've been doing this for quite a bit of time. I started out as a teacher, and then I moved into a director role, and then and just ended up landing in a rehab facility where I worked with biological mothers that were pregnant and going through rehabilitation for substance abuse. So it was a very interesting experience to be working with both the biological mother and her unborn child that she was pregnant with that was most likely going to be diagnosed with NAS. So I have a lot of experience working with lots of different family dynamics. And when I first started that job, I remember the director asking me, have you ever heard of NAS? Have you ever heard of Neonatal Abstinence Syndrome? Have you ever worked with children that have, been diagnosed or have any opioid exposure? And I had not. And at that point in time, there was very, very, very little information out there. There was very little research. There definitely was not a Generation O back then. That would have been very helpful. So I was like, well, I'm going to do everything I can to find out all the information. And that's what I did. I did a lot of research, and I have been working with children that have had opioid exposure for the past almost 12, 15 to 15 years. So this is very much something that I'm dedicated to and really love working with children and families. So I did want to go ahead and get started with going over some definitions that you'll hear throughout the presentation. So NAS is an acronym short for Neonatal Abstinence Syndrome. It's where a child is born and undergoes withdrawal substance exposure that they had in utero. So that is more of a broad term. That is something that it can be exposure to many different substances, even benzodiazepines, antidepressants. There's lots of different substances that they can be exposed to. And a newer term that we're hearing more being used now is NOWS, NOWS, and that's neonatal opioid withdrawal syndrome. That is one that is specifically for opioid only withdrawal. Um, and so I'm going to share some more information about that too. But you will probably hear me use different terms during our time together. I like to say substance exposure, substance exposed child, in utero substance exposure, but I will also say NAS quite a bit. So this is a little bit more information about what can cause NAS. What are some opioids that the mother would have been taking during her pregnancy? There are different classifications of opioids. There are medicines that were prescribed by a doctor. There are medicines that are synthetic. Those are the ones that are that you may have heard of, like Suboxone, Subutex. Those can be prescribed, or those can be ones that have been purchased illegally. There's different types of opioids, and I have those at the bottom too, like heroin. Fentanyl is a lot in the news now. You'll hear a lot more information about that later on. Methadone, oxycodone. So there's a lot of different types of opioids. Opioids is the classification of drugs that most likely will cause NAS. Some information about diagnosing NAS. I always like to share this information too. One of our scales that we used to use that's a little bit more outdated was called the Finnegan scoring. That was more when we were seeing an epidemic of children born with substance withdrawal. That was typically about a 3-week stay in the NICU. So the scoring that they were using it was very subjective too. So the nurses and doctors would be scoring the child after birth and being able to see like how they're sleeping, how they're eating, how they're breathing, all of those different things that they're monitoring. We now are moving more towards this eating, sleeping console, or the ESC care tool. And this is more of a mother and child, or caregiver and child connection. It's more about rooming in with the child instead of taking them immediately to the NICU. A lot of skin to skin contact, swaddling, swinging, soothing, and more in-depth increased calorie feeds. So this approach has been shown to have more success over time. I even got some of the statistics that I pulled from the Generation O website that I was looking at. I had not had those updated yet, but it does show that there is a shorter term in the NICU stay using this approach. It is more of an approach it's more skin to skin care, more working with the infant rather than over medicating them. So there are shown a lot less stay in the NICU and less likely needing to use medicine, which is fantastic. And I have seen this personally too. A lot of the children that I've worked with that have not needed to take medication do seem to be recovering a lot faster from their withdrawal symptoms once they are returning home. Some health risks. We're going to go over a little bit of like the background information. I always think it's very important to know a lot of what is going on with their development in utero. What are some complications that we might see? What are we seeing with their brain development? Because I do think it's important to understand all of those things as we move further on to looking at long-term implications. So some medical complications we see with substance exposure, the number one would be prematurity. A lot of these children are born pretty premature, and I think if it's a younger than 30 weeks, they can be diagnosed with just prematurity. So there are a lot of medical records that I would read for a child that I know was substance exposed, but they were diagnosed with just a prematurity, which prematurity has its own medical complications too, with breathing rates and a smaller weight, smaller head size. A lot of those things can be their own complications with that diagnosis, but prematurity is a very large prevalence in children that have substance exposure. Low birth weight is another one. Respiratory distress. We see a lot of children needing a lot of help with respiratory after they've been born. Smaller head size, which also has its own complications with smaller brain and smaller facial features, which we'll talk about in a little bit. Heart defects is another one. We see some complications with some cardiology diagnoses. Hearing and vision loss is also something that we see even more increased rates recently. I am going to talk a little bit about that later as well, but I do think that hearing and vision development does sometimes take a back seat because there are so many other things that we're focusing on. Of course, like with their breathing and their birth weight, are they able to gain weight? Are they able to keep formula down? You know, are we able to keep them comfortable? So hearing and vision loss, children that are substance exposed sometimes will get a failed hearing and vision scores when they're younger. And then with all of the other things like therapies and doctor's appointments, sometimes the hearing and vision sometimes does not get as much attention as it should. And we see that later on, that when there are hearing issues that can be associated with NAS or vision complications. And then stillbirth and sudden infant death syndrome are also pretty some medical unfortunate complications from the substance exposure. Some other high prevalence with in-utero exposure, and this does not mean that the child would have any of these complications, but it is something that we do see there's a high prevalence. Sensory processing is probably the number one thing that I see associated with NAS. There's also learning disabilities or developmental delays. ADHD is also something that's pretty common that we will talk about a little bit later, especially when we talk about the older children that are in elementary school. Failure to thrive is pretty common too, with children that have NAS, with having GI problems, having a hard time keeping formula down, having a hard time maintaining their weight. We'll see failure to thrive as a diagnosis. Sleep apnea, seizure disorders, a lot of those complications too can disrupt brain development and having the child be able to grow. And then the other ones I listed, we are seeing a higher correlation of autism. I'm trying to do more research and find any research that is going with NAS and autism to see, because we are seeing an increased diagnoses of autism too. But again, that's, you know, moving forward with our new ability to see symptoms sooner and having more information about autism now. But a lot of these are some commonalities that we see associated with NAS. I'm not going to spend too much time on specific symptoms of infancy. I think that we're doing a better job now sharing information about NAS symptoms in infancy. You know, 10, 15 years ago, this was still something very, very new. I think we're doing a much better job with sharing this. It's more of our what happens after they leave the hospital. What do we do after we no longer have a nurse there 24/7 helping us with feeding and monitoring their weight. So, but these are the most common symptoms we see in infancy. I put some pictures over here. The one on the bottom is mottled skin. A lot of people don't always ask what mottled skin is. It kind of looks like where you can see the skin looks a little bit light, where you can kind of see through it, where you can see like the little red like veins. Tremors, seizures, twitching are very, very common. That's pretty much the first one that people will notice. They look like they're convulsing. It's a pretty scary thing if you've ever seen a child have any of these tremors, and they last for quite a while. I've had children that are as old as like 12, 15 months still having some twitching or tremors ever so often. You see it more often when they're overstimulated. So during diaper changes is a time, changing clothes, changing positions. Those are times that sometimes can induce some of these tremors or twitching. High-pitched crying, excessive fussiness. That's another one that if you've ever heard of a child that has substance exposure or NAS cry, it's a very high-pitched, almost. I have a baby a baby doll that does like the sounds of a baby with NAS crying, and a lot of people will see it and their eyes get really big because it almost sounds like a chipmunk. It's very, very sad. Hypertonia or muscle stiffness, like high muscle tone. I like to describe that as like a Barbie that's like stuck in one position where it's hard for them to move their limbs. that is very common with NAS. Sneezing, nasal stuffiness, that's another one. If you have a child, even like a typically developing child, sneezing in infancy is a very common symptom of them being overstimulated. So we see that a lot when there's a lot of noises going on. If you're going from inside to outside lighting, that is something that you might see that you'll see a baby start to sneeze, but you see it even more with a child with NAS because they are even more overstimulated than other infants their age. And then the other ones that we see, like the excessive sweating, fever, yawning, diarrhea, vomiting, disorganized sucking is another one where it's hard for them to have a rhythmic sucking pattern. Those automatic things that we take for granted, like breathing, blinking, sucking, they should be like your heart rate. It should be very rhythmic. And we see with infants with NAS, it's very disorganized. Even with their breathing, if you watch them breathe, it's kind of like rapid and it's not regular. Some other things that we would see that would help with overstimulation, and this is even for older children too. Swaddling is something that is that's like the number one thing that we always suggest. Have you tried swaddling? So that is getting them really stiff, putting them in that little baby burrito. It feels like they're in utero. That is what's very calming to them. Breastfeeding is something that is helpful too. That's kind of like the very basic co-regulation. They're doing that skin to skin. They're feeling their mother breathing. They're feeling the heart rate. Reducing environmental stimuli is very important. So keeping the room darker, keeping the temperatures cooler. Children that have been substance exposed, even as they get older, are very, very easily overheated. So the lower temperature, the better. A lot of people, like especially if it's a grandparent raising their child, I will go to their house, and we know as we get older, we like our environment to be a little bit warmer, and that can be very overstimulating for a young child. So I sometimes will even keep like a thermometer or in their room to see what the temperature is, because we may need to get some fans to keep the environment a little bit cooler. Massage is another one. Skin to skin contact we talked about earlier. Containment pressure is something that we can try with infants that is not something that's used a lot, but it's where you, in the picture, there's a picture that I put there of someone holding the bottom of the feet and the head, and you're pushing inward. That makes it feels like the child is in utero too, like they're inside the tummy and they're pushing up against the uterine walls. So that is something that can be really helpful as well as laying on their side. A lot of times rolling over to the side can be helpful, and an elevator rock, which is basically like doing squats. You're going to hold them up against you and you're going to go up and down slowly. With children that have GI disturbances, it's very difficult if they are rocked back and forth like we would typically with an infant. Going up and down can be less stimulating. So that is some tips. Other tips for helping with infants with overstimulation: a swaddled bath is something that I highly recommend. If you have a child that, and this can be even like as an older child, if they are overly stimulated by bath time, that is probably, besides feeding and sleeping, that's one of the number one things that I get questions about. How do I give my child a bath when they're screaming nonstop? So you're going to get them really tight in a swaddle and then slowly submerge them into the water until they are comfortable. And then you'll bring out their leg and wash their leg, wash the other leg, and then slowly unswaddle and bring out an arm and the other arm. It helps them acclimate to their environment a little bit more than going freely open into a tub. So that's been really helpful. As they get older, doing stand-up diapering and doing dressings, anything that you can doing it standing up versus laying the child down. That can also be helpful. We know that changing positions with a young child can be challenging. A lot of times when parents will ask me about how do I change my child, they act like I'm trying to hurt them when I'm trying to just change their diaper. It's usually that going from up to down position. So doing anything you can standing up when they're a little bit older is helpful. If you can't do that and they're young, then you're going to do a lot of sandwiching against their body. So you're going to hold the child and you're going to sandwich your arms against them. And as they go down, you're going down with them to the diaper table or to the floor or wherever you're taking them. And you're going to use your body weight to kind of sandwich them and push them up against the diaper table or the floor or the bed. And then you're going to remove your body and keep your hands there. And that's going to add that pressure to their body to where they know where their body is in space, versus taking them and laying them down can be very overstimulating for a child. And I see that even with our older children, being able to move quickly, it can very much overstimulate them. And vestibular sensory system is probably, to me, one of the hardest ones to kind of regulate from. It lasts for a couple of hours sometimes. So that is one that I'm very very adamant about, like teaching people to do more pressure with the body to help that child feel safe. Some other ones would be like adding some pressure to their car seat. I'd always am monitoring these children, so you don't want to like walk away and leave stuff in their car seat or sandwich them in. But if you have a child that's in the car seat and you see them constantly rubbing their head and moving them, they may need more pressure on their head. And OT shared that trick with me a long time ago with rolling up diaper cloths and putting them next to their head. And of course, once they're stable and regulated, then you're going to remove them. And also do it like after they're in the car seat, then you can do a swaddle in the car seat. As a child gets older, you could try weighted objects, putting like a weighted blanket on them. This would be like obviously after they're like 1 year old. Having them hold things that are a little bit heavier. I used to have a kid that would like bring the most random, heaviest things he could into the car so he could keep them on his lap. And that's what he's doing. The car is also a very fast, like changing positions thing. A lot of children really, really hate being in the car seat. So anytime you can add pressure to where a child can feel their body can be helpful. So the sound machine is also beneficial. Cracking your windows to where they have that white noise. And a lot of times these children are very, very overheated in car seats. I mean, it is like a hot box in there. It is really, really warm. So I love these new little portable fans that you can claw on to anything. Those are really, really helpful. So if you're in a restaurant that's kind of loud and they're getting hot and their body systems is pumping that blood and getting everything moving, they may be getting overstimulated. They may be getting way too hot. So using some of those fans can be helpful.
Usually like to go a little slower because I know you wanted to do the documentation about it.
Okay. So the next thing we're going to talk about is brain development. I put this on here because I thought it was really important to see all the different areas of the brain and what the brain does. So one of the areas of the brain that is the most affected when we're looking at MRIs, when we're looking at brain scans, we see a lot of gray matter in the frontal lobe area and in the prefrontal cortex, which is a lot of that green and blue area of the brain. So I tried to color code it to also make it easier to see. The green area is that frontal lobe. That is the area where is control of movement. Is it in control of executive functioning, which I'm going to talk about a little bit later, but your executive functioning part of your brain is a lot about reasoning, planning, judgment. It's a lot about your working memory. So when I say go to your room and put on your socks, are you going to be able to hold all of that in your brain and to know that you need to go to your room and then what do you do next after you get to your room? So executive functioning is something that I see as a lot of challenges in schools. It's a lot, and that is also associated with ADHD. being able to stay focused, being able to stay on task, being able to follow the rules every single day, even though you have been doing this since you started kindergarten, that you know every day we go and put our backpack up and we go and get our morning work and go sit down. That is very, very challenging for someone who has had some frontal lobe disturbances, which is what we are seeing with children that have opioid exposure. So no wonder these children are not always doing excellent in school. It is very hard for them to be able to follow routines, be able to plan ahead. I'm about to go to the cafeteria. I should probably go wash my hands and get my lunchbox and get in line. Even though we, again, have been doing this since day one, it's very hard to plan ahead. Or, we're talking about older children. Like I have a test on Friday. I should probably look at my stuff and start planning ahead and starting to study and looking at these things and becoming familiar with them. That is something that is very, very challenging for someone who has executive functioning differences. So some of the other areas like the lobe where it says the sensory discrimination, I need to move my videos. Okay. The sensory discrimination, this is another area of the brain that we see where sensory processing is happening. That is something that is very challenging for children that have been substance exposed, where like temperature regulation, pain, that is something that is huge. That when you have a child that is having behavior challenges, they're very much a risk taker and they have a very low pain tolerance, is a very hard thing to teach a child consequences when they're jumping off of something and they don't feel pain. So you can kind of see how some of these things together like can make things very challenging for the child in different environments at home and at school. Body awareness is another one, which we'll talk about a little bit later, but knowing where your body is in space, even as an infant, when I was talking about doing the diaper changes, knowing where your body is in space when you're standing in line at school, knowing where your body is when you're laying in bed and not constantly rolling over someone or laying on top of someone when you're just trying to sit next to them. So the other areas we will talk about too, like the understanding language. We see a lot of auditory processing challenges with that area of the temporal lobe. With brainstem, there is a lot of connection with your brainstem and how your body is processing breathing and your heart rate and your blood pressure, but also digestion is another one, and how that is affected with like your brain gut health. And then your attention and language processing and your development coordination. We're going to discuss all of those a little bit later. But I do want to talk about NAS is not just about the withdrawal symptoms. I've heard doctors in the past say NAS is just a diagnosis that we have for that first, period of life, that for less than 12 months when they're going through the withdrawal symptoms, and then NAS, that's no longer a thing. They're not affected. And that's absolutely not true. Anyone who's ever met a child that has been substance exposed, or if you are a parent with a child that has NAS or substance exposure, opioid exposure, we all know that NAS does not just go away after they leave the NICU, that there are some long-term implications. Does not mean every child is going to have a developmental delay, does not mean every child is going to have behavior challenges, but there are some long-term implications that we may see going forward, which is what's so great about being able to talk about all these things, is that we can know what to look for, know how to help, and know how to be proactive and do early intervention. Sleep disturbances is probably, besides feeding, probably one of the number one things I get the most questions about when it's associated with substance exposure, because we like to sleep. We are humans, we like to have sleep. And so when we are constantly being woken up throughout the night, it's very challenging. So very motivated to get these children to sleep. For infants specifically, like we talked about before, swaddling, containment pressure, cooler temperatures, limiting your environmental stimuli. As soon as I go into a house, I'm like, do you have a sound machine? Do you have a blackout curtain? using all of those things to kind of help get the child comfortable so they're not overstimulated. Because if you're overstimulated, you're not going to be able to sleep. Continuing these things throughout the night too. Don't just have the sound machine on for the first hour, but having it on throughout the night. One tip that I always have is that however you're sleep training or teaching a child to go to sleep is how they're always going to need help going back to sleep. So if you're having to rock this child to sleep every single night, then you're probably going to have to rock them in the middle of the night when they wake up. So knowing that ahead of time, I always try to tell people that's why the sound machine should not go off after like 2 hours. It should be continuous throughout the night. The top picture is one of a baby that I've had on my caseload before. With that hypertonia, that high muscle tone, it's very difficult for children to be placed down into a flat surface into their crib because their muscles are very stiff. They like to stay bent. So when you're putting a baby down on a flat surface, which is what we're supposed to do for SIDS risk, and everything should be out of the crib, you're putting them down and then they're not feeling comfortable because they're used to being bent. So when you put them down, they're going to do that startle reflex and they're going to wake themselves up. One trick that I have is using a rolled up towel or rolled up blanket. So when you're putting them down, then you can slide that under and it can kind of feel like they're being held. So that's where they would be being held. Their legs are bent the same way. That's why swings are created that way, because it makes them feel like they're being held. So like car seats are made that way because their bodies are bent. That's why a lot of children with higher muscle tone really enjoyed being in those positions better than being flat on their crib. So this can be like a little trick to transition them into their bed. Again, it's not going to be long term. It's going to be until you can kind of see that their heart rate is slowing down, their breathing is slowing down until they're getting into a deeper sleep. And then you'll remove that towel and then their body will be able to relax a little bit more. The bottom picture is of my daughter when she was around the same age. And that's the Magic Merlin sleep suit, which I am completely obsessed with. It is pretty thick. It's like a snowsuit, but it's very stiff for a reason. So when children do that startle reflex and they jump and they wake themselves up, that kind of helps reduce that. Children that have been substance exposed will have like that retained startle reflex for a while. So that's why swaddling really helps. This is a great transition if they're not able to be swaddled, is using like this little sleep suit. And she's like trying to move her arms, but she's pretty stiff. So it can work wonders. It is a little bit hotter because it is thicker, like a snowsuit. But I usually suggest putting them in there in just their diaper and keeping your room really cool. I've ended up buying like 4 of those because also just be aware that they take like days to dry because you're not supposed to dry them in the dryer. So if you have a blowout, you're going to need a backup. So some other options I put on here. Oh, I think I didn't talk about the terry cloth sleeper. That's also a physiatrist had recommended that to one of my families, and it was a game changer. So that texture of a terry cloth, they ended up flipping it inside out. So not using it where the terry cloth is on the outside, but flipping it inside out to where that terry cloth is brushing up against the skin. Another strategy would be to use a terry cloth liner on your bed. So those waterproof liners that you're going to put on your bed, whether it's your mattress or a crib mattress, you can buy them and they're like terry cloth texture. Those are perfect for a child that you can kind of tell is like rubbing their head on things. They're seeming like they need more tactile input. That is perfect for that. So I've purchased those for families where we put them on as like their crib sheet. You're not going to put a sheet over that. They're going to sleep on that like textured terry cloth like liner, and it's going to add more like tactile scratchiness to their skin, and that is going to help them relax a little bit. So that was a trick from the physiatrist here in Tennessee that was really helpful. And then some of the other ones, you've probably seen these, like they're way more popular now than they were a few years ago. But I'm a big fan of the Dreamland Sleep Sack, especially because you can get them as they get older. They add a little bit more pressure. Those little diamonds have a little bit of like weight to them. So the nested bean is another one where it kind of feels like there's a hand on you. The little chick on there has like some beads in it that feels weighted. So a lot of different options that we have now that we did not have like 15 years ago that can be really helpful, especially for children that are substance exposed. Oh yeah, here's a picture of the mattress protector. This is the brand that I use. And it's just, it's just a tactile, like little, almost feels like you're sleeping on a towel, which does not sound comfortable to most people, but it's like very scratchy. You could also just use a scratchy towel. We've done that in classrooms before, like for children that are in preschool. I'll use like a scratchy towel and put it over their sheet on their cot, and they'll sleep on that. And it's another way for them to get some sensory input on their skin. Compression sheets, those can be really helpful for anyone. I love a good compression sheet. It's basically like putting a sock over your mattress. It goes over the whole thing. And so if you have a kid that is constantly moving and they just cannot seem to get settled, this is very, very helpful. It's like sleeping in a really tight like sleeping bag. So I've made those before for cots. You can buy them. We're just great that we live in a time where we can buy things on Amazon. Back then we just had to like create these things ourselves. But this is really, really helpful. Weighted blanket is another one that's way more common now that you can buy those even at Walmart. But I always put a little asterisk there, like, talk to your doctor, because that is technically like a medical equipment thing. There's like a specific weight you need to know for how much weight to do on a child, and they need to be a certain age. Other tricks would be weighted stuffed animals. Those are really helpful for so many different reasons. Holding a weighted stuffed animal in the car, especially a child that's like a little bit older, like 12 plus months, holding that in the car can help them feel very safe. Holding a weighted stuffed animal when you're at the dentist, holding a weighted stuffed animal when you are getting your hair cut. A lot of those things help reduce the anxiety of things that are going on. It kind of helps ground them a little bit. And then other sleeplessness strategies like heavy work, I'm going to go over in a little bit to kind of tell you more about what heavy work is if you've not heard of it before. But another one that I'll talk about is reducing screen time before bed. So typically screen time can be pretty stimulating for children. Some people don't know that, but at least like an hour, if not waiting until to be done with screen time after dinner, is really helpful to get the brain regulated to get them ready for bed. I have seen a lot of children that watch screens as they fall asleep, and then they need the TV on all night long. So then when they wake back up, they can watch TV and go back to sleep. That's not very healthy for brain development. So going ahead and starting those boundaries of like after dinner, we are done with screen time to really help everybody get ready in that, get their brain ready for bed, because with all the chemicals that are going on, it's stimulating the brain and it takes a while to get them regulated. This is a picture of one of the little weighted stuffed animals. You can get those anywhere. You can get them at Cracker Barrel now. They're like the warmies, which sometimes smell really good. You can put them in the microwave and have them warm. I bought one recently that's a penguin, and you can put it in the freezer. So our kiddos that are really hot, that's also really helpful too. Having one that they can cuddle with that's a little bit colder. All of these recommendations on this page need to be discussed with the doctor. That's my little tag of information. I'm not a medical provider, but these are things that I tell parents that to go talk to your doctor, talk to your medical team, talk to your therapy team about. We do see a lot of children that have substance exposure having lower levels of potassium and electrolytes. So that is something that I ask parents to continue monitoring. I didn't put it on here, but iron is another one that sometimes can be a little bit lower for our kiddos that have substance exposure. Melatonin is another one that's after a certain age, you can start discussing with the doctor. Just as a note, I don't think I put that on here, but if you're doing medicine or anything, make sure that it's dye-free. We see a lot of adverse reactions to medicines if there's dyes in them. Clonidine is something that can be prescribed by a doctor after the age of 18 months. And that is a substance that needs to be monitored through the doctor. So clonidine is a controlled substance. This is what I was looking for. It's a controlled substance. So that one can be pretty tricky. But if you have a child that just does not sleep and needs a lot of help falling asleep, clonidine might be something to discuss. Magnesium is another one that you can get as a lotion. You can get it as something you can put in the bathtub. But they also have gummies that you can do. And omega supplements is another one that we see that the physiatrist that I worked with had suggested. And I have seen a lot of success with magnesium and omega supplements. They even have gummies that combine both of those that have been really helpful for some of our children. And then the other ones we've talked about before, joint compressions and brushing are two things you would need to talk to an OT about, but we do see a lot of success with both of those as well. I'm not going to go into this. I just put that on here so when I share my slides that you'll have this information, but really it just kind of goes into making sure you're aware of how long a child needs to be awake in between their sleeps. So if I go into a house and I'm doing a visit with a family and they say that they have a 6-month-old that never sleeps except at bedtime, that is not great. Or how long is it that they take naps? They take 1 nap a day. So this chart, I usually print it off, put it on the fridge, and it lasts for usually 4 years for you to know how long in between naps a child should be awake and when you need to have that wake window. This is really, really helpful to know. So you know that if you go over that wake window, you're going to be working backwards to get the child regulated to be able to go to sleep. All right, some feeding and digestion. We see a lot of challenges with keeping formula down, with extreme vomiting, loose stools, diarrhea. Those are some common things that we see with substance exposure, and we see them too as they get older. Sometimes they'll even go in between like a chronic constipation versus diarrhea, back and forth. One thing that I do share with people is that children that have substance exposure typically have a high correlation of a milk protein allergy. So that is something that's really important to just be aware of and know the signs of what those sensitivities and allergies look like, which I'm going to show. This is my daughter who has a milk protein allergy, and this is what happened when we finally realized that was the issue, and it wasn't colic, and it wasn't me just being a hysterical mom, that actually it was something going on that you would not think a child that has a milk protein allergy would have a rash and hives, but that was how it ended up presenting, and then ended up, having bloody stool, which is a very big wake-up call. So a lot of the times these things go missed because they look very similar to substance exposure symptoms. So a lot of times doctors will dismiss that is just something you see with NAS. That's to be expected. We expect children to have diarrhea and vomiting and nasal congestion, trouble breathing. I literally just said all of that earlier. So why would you think that would be a milk protein allergy? The biggest ones that I start on here is that you'll really know it's an allergy issue is if they start having mucus in their stool, if it's starting to turn green, especially if it's a child that's not breastfed. It starts to smell sour, like vinegar, or if it's a really, really, really strong smell that, it's that is not normal. That is probably an allergy. Bowel movements, the screaming at nighttime, unable to be soothed, just like they're in pain. So a lot of the times it is an allergy You can ask the pediatrician to do a simple test. They will literally just do a fecal test and swab it on something to see if there's any blood in the stool. Even if you're not seeing anything red, it can show up in that swab. So that's my soapbox for the milk protein allergies. So other things, and this is on the Generation O website, the things that we would see, like the frequent vomiting, having difficulty with diarrhea, loose stools, things like that. I love that there's even a whole article on their website that's just about diaper rashes, because it's such a huge thing that we see. If you have a child that's having constant diarrhea and loose stools, they're going to develop a diaper rash. So it's really helpful that that information is on there. So I talk about it all the time. Like, I don't even have to like share anything. I'm like, go to this website. It has all the information. But my favorite thing is the Calmoceptine. I recommend that to everybody. You can buy that on Amazon. You can buy it at Walmart. You usually have to go to the pharmacy to get it. It's over the counter. But that is absolutely fantastic. It has, the biggest thing is like having that zinc oxide, and the powder mix is, and that's what's in the Calmoceptine plus calamine lotion. So that's really helpful. And also using things like water wipes versus like the scented that smells so good, baby wipes, that's going to irritate the skin more. This is also a NICU nurse gave this to me. She was saying, like, you can go to the pharmacy and get, them to mix these things for you, or you can just go home and get the zinc oxide, which is usually the purple Desitin, and then mix it with cornstarch or baby powder and make your own. And then you're going to put it on the skin as a barrier, and try not to wipe that off every time you do a diaper change. It's going to be like a barrier cream. So we see that happening a lot, even as children get older. Trying to help protect their skin is going to be so crucial, because we do not want them to have anxiety about going to the bathroom, because as we're starting to toilet train, it's going to be very challenging for a child to feel comfortable going to the bathroom if it irritates their skin every time they go. Okay. So now we're going to get into some behavior challenges. So this is like when you look up behavior challenges or toddler life, or any of those things on Google, this is the image that I saw that popped up, that I was like, if this doesn't say like NAS, because I was working in childcare, and I was a director of our center, and every single child there had NAS, every single one of them. And so when I would go to trainings, or I know everybody has to have CEU, so I would go to stuff, and they would give us ideas on strategies to use, and I'm like, well, what do you do when a child is like, scaled the wall and they're like on top of the cabinet and you can't reach them? Or like, what do you do when the child is like, swinging from the chandelier? Or, I mean, like, what do you do? Like, there's no way that they didn't have any strategies for me, but I'm like, this happens all the time. There is that impulsivity and that risk taker and that quick to react is like a really horrible combination, because like I said before, kind of paired with that really low pain tolerance, you're going to have a child that's going to be climbing everything because they have no fear and they have no pain most of the time. I've had a child that I worked with that the mom ended up falling while she was holding him, and he cried for a little bit, and then he was fine until probably like a week later he stopped crawling. And when she had taken him to the doctor, that everything was fine, but she went to another doctor and got a x-ray, and he had broken his tibia and did not cry for the entire week, was absolutely fine. So we just didn't notice it until he stopped falling. So, I mean, that's like one of the most painful bones to break, but yet very, very, very high pain tolerance can be really, really challenging with parenting or being a caregiver, because you're not going to pick up on when a child has an ear infection until maybe stuff starts draining out of their ears, or that they even have a fever because they're always really warm. So the behavior challenges sometimes can be linked to other things, like not being able to sleep very well, not having a good calorie intake, and adding dyes to their diet, excessive screen time. Like there's a lot of things that kind of bubble up that can cause some of these things, but it's very common to have behavior challenges. Aggressive behavior, breath holding spells is another one that's really fun to deal with. But there are things that we can talk about that can help with some of those symptoms that you're seeing. One of the things that I do talk about when we talk about behavior is, what is this child trying to communicate to us? What are they needing? Are they climbing because as soon as they climb, mom and dad actually look over at them and they get full one-on-one attention? Are they climbing because their body is needing to move, that they're needing to climb? It feels good to get their body moving. Are they climbing because, they wanted a cookie that's at the top of the fridge and that's where, grandma hides them? So what are they communicating to us and what are they needing and how can we help them with that? Support and attachment is number one foundation of development. So does this child have a good attachment? Do they have at least one person in their life that cares for them and is consistent with them? That is the number one focus. So really being able to strengthen that attachment with at least one caregiver, exposing the child over and over again to what's developmentally appropriate, and then having that caregiver-child relationship. And I will say that working with families, whether it is like grandparents or a foster family or biological family, when you have a child that has a lot of needs, very high needs, is not sleeping, is having a hard time eating, and there's like around the clock care, it is really hard to bond with them. So that is something that early intervention is so important, to have someone to come and help you with those things, or seeking out therapy as a caregiver to really heal those relationships, because that attachment is the number one thing that, like I said, is going to be the foundation of their development. So Bruce Perry, Lynette knows how I'm a big fan of Bruce Perry. Every one of his books are absolutely amazing. What Happened to You is something I always recommend. And also is it The Boy Who Was Raised by a Dog? I think that's the name of the title of that book. That one is also a really good one, but it talks a lot about trauma. And that is a very hard thing to talk about when we're talking about NAS, substance exposure, is that the brain did have trauma. So we are talking about a child who, even in utero, even if they were born and they immediately were given to, their mom and we're talking about in utero trauma. So even then, even if they've never seen anything, nothing has ever happened, I do always talk about that, because that is something very important with brain development, that they were exposed. Even in utero, there was trauma there. And Bruce Perry has a lot of information and ideas and support for people that have trauma. This is also something I think is really helpful to visualize. I'm a visual learner, but when I'm talking to people about what behavior you are seeing, is like looking at a tree, that we're seeing the beautiful leaves and the branches. We can see the behavior. We can see the child is climbing on top of the fridge right now. I see what is happening. That's the behavior. The feelings are the roots underneath the tree. You don't see the roots. What feeling is leading that behavior? So being that detective of like, what are they trying to tell me right now? What feeling is leading them to behave this way? Is it that when I throw my cup off of my high chair, that, my adult puts their phone down and they look at me, and the feeling is I want attention right now? So what feeling is leading that behavior? And that sometimes itself can help with a lot of behavior challenges. If it is just the connection, then we need to build on that connection. And a lot of times you will see the behavior decrease. If it's a challenging behavior, you definitely want to focus on what you want to see more of. That's my probably number one tip. If you want to see them being kind to the family pet, you're going to focus on every single time they're kind to the family pet. You're going to focus on what you want to see repeated. These are some things that are probably a little bit more for my educators in the group. but really helpful for really anybody. If anyone ever wants any of these pictures, I have like a million picture cards on my computer. You can probably even look up, just Google like visual supports for children. I still use visual picture cards for my daughter in her daily schedule every single day, and she's 8 years old. That every single day she goes to her chart and she knows it's time to put backpack up, do homework, get a snack, all of those things. When you have a child that has challenges with executive functioning, being able to think through every single step of what they're supposed to be doing is very, very difficult. So you may even have to start with just like, first we're going to brush our teeth and then we're going to play. Or first we're going to change our diaper and then we're going to eat dinner. Just even seeing a picture is really helpful for children to be able to understand what they should be doing. So if, again, with that, auditory processing is a high correlation with NAS. Being able to hear what you're saying and following through with it. The picture cards are going to be so helpful. You can say it a million times, but if you show them a picture, it's really helpful for following directions. Visual timers are also really helpful, staying on task, that you have 10 more minutes until it's time for us to leave for school. You have 10 minutes until we're all done with dinner, or, oh my goodness, we have 10 minutes until we get to leave to go to grandma's. So the timer is that visual aspect of being able to know what is going to be happening, what's going to be happening next. And that's, I mean, gosh, that's really helpful for anyone. If you're going to a presentation, you're going to want to know, or like a meeting or a conference, you're going to want to know exactly when is lunch happening. I want to know what's happening next. So this is helping kind of build on some life skills. I put some video resources on here that when I share my slides, you'll be able to click on those and look. But the how to help children develop executive function is really good. And then the Brain Builder series is absolutely amazing. But I really like this executive functioning one because it gives some good visuals of like all these different hot air balloons, trying to say like, learn your ABCs, tie your shoes, go put on your socks, like all these things that are like in their head. And it's just like air traffic control is not doing its job and they're all getting mumbled. I think it's a really good visual of when you have brain differences, it can be really challenging. And it can be difficult for someone who is deaf to be able to learn language, or someone who has cerebral palsy to maybe learn how to walk. It may not be able to be as easily seen. It may not be something that has a braces or a hearing aid or an eye patch, but executive functioning is something that is a brain difference. So knowing that and knowing that this is an invisible disability and that this is a struggle they have, a lot of times helps us as caregivers and providers to have more empathy that this is something that they cannot help. So these videos, I think, are really helpful. And even the why do we lose control of our emotions is like a cartoon. I've shown that to adults and I've shown that to children, like, elementary school children. It's really a good visual for them to understand about like flipping your lid and what happens to your brain when you lose control. So some sensory, we're going to move quickly into sensory processing. There are the senses that we all know. If you're not familiar with sensory processing, thankfully, it is becoming a little bit more well-known the past couple of years. When I used to bring this up 10 years ago, people looked at me like I had two heads. No, we only have 5 senses. We learned that in kindergarten. Vision, hearing, smell, taste, and touch. But there are also 3 invisible ones that we don't talk about a lot, and that is proprioception. So that is your body awareness. Vestibular, which is movement. So earlier when we were talking about changing body positions, that's vestibular, like your inner ear. And then interoception is your internal sensations. It's how your body gets internal signals to your brain that you are hungry, that you need to go potty, that you are really hot right now, that you are very dysregulated. So if you're having lots of challenges with your sensory system, where the sensory processing disorder is an actual disorder, it's where there's impaired processing of your sensory input. So what I like to say is that if the energy level does not match the activity, or if it is starting to affect your daily life, like we all have sensory things going on. You even hear people say like, oh, that's sensory. Like I remember I don't like having my socks feel a certain way, or I don't like that yogurt because it has chunks in it and I don't like the way that tastes, or it's too chewy for me, or oh, that's way too strong and smelly. We all have a sensory system. We all have levels of sensory, like where they're overactive or underactive. It's when it starts to affect your daily life that I can't go outside because the sun is so bright that it makes me want to throw up. I can't go to the store because there's so many crowds that people might touch me and that I don't like to be touched. Or I am going to scream and never be able to wash my hair because I hate the way the shampoo feels on my head. So when it starts to really affect your daily life is, when we need to be talking about sensory processing and discussing that with a doctor and OT. Some things that I see more common than others I put on here. I usually see pretty young is rubbing their head along the floor, like when they're learning to crawl. That's something I see a lot with children that have sensory differences, or they start to bang their head. Scratching, mouthing, smelling non-food objects. I have a little boy that I work with that's 3 that still, puts everything in his mouth, is like chewing wood and drywall and everything he can get his hands on. He's a very much oral sensory seeking. Having difficulty sitting still, you can see why that's very much related to ADHD. Never seeming to get tired, having difficulty falling asleep, having a hard time like getting into that calm state. They just kind of seem like they're always on the go. Let's see some other ones. Under responsive to taste. One thing that I'll ask families if they're a difficult eater, like they're a picky eater, or they're just not really seeming to be interested in food. I'll ask, like, have you given them a lemon to see what they do? And if they're like, yeah, I did, and they didn't even react to it, that's usually a sign that there's like something going on with their oral sensory system, that they could be needing way more intense flavors and textures. If you give, like, that was my first red flag for my daughter when I gave her a lemon. She had 0 response. I'm like, oh no, she is going to need way stronger flavors, like spicy foods and more intense textures. So a lot of these things are things that I see in young children, that I start making like little mental notes that this could be coming, that we're seeing some differences in their sensory system. Heavy work activities are helpful for all children. All the stuff that we're going to talk about can be done with any child, any person. It's nothing that's very specific to children with NAS. And if you do it, then you're going to ruin your life. These are all things that any child can do, any person can do. Like, some people really like to go and work out before they go to bed. Not everyone can do that. Sometimes that makes you too hyper and you have a hard time falling asleep. Some people need that. Some children need this. Sometimes they need to carry heavy things or move things around or push and pull them before they go to bed. A lot of times these activities will be things that can help regulate the body. So things that we see now, like brain breaks, are very popular in school. There's whole science behind that. There's a reason why. Getting their body up and moving and getting them to do things like yoga and jumping up and down and running in place and going up downstairs, all those things are for a reason. It helps calm the body and helps the brain focus, or helps the brain regulate. So heavy work activities, you can even Google that. These are my favorite ones for young children. Carrying heavy items, so helping, mom and dad carry in groceries, filling up baskets with items and having them pull it around the house, helping take out the garbage, helping push and pull. Like, I had a little girl today that has NAS that I work with, and she helped me pull the nap time carts to all of the classrooms. She is 3 years old. So, they were very heavy. And so we pushed and pulled them all the way to the classrooms. Or when we go to the grocery store, she's going to really help me push the cart. going to give her way more weight to push.
Here, honey.
Um,
Here, drink.
jumping on a trampoline, pushing heavy objects on a sheet, or having them wear a backpack. If you guys are going to be walking around the neighborhood before bed, you need to put some weight into the backpack, like add some bottles of water, add some books in there, have them, it's also really popular now for like people to be wearing weighted vests. The same for children, like add a little bit of weight to them. If they're going to be riding in a little sit-on car, like a bicycle, add some like weights to those things so that it's making it a little bit more challenging. Some other calming, these are things that can be done to help with calming, especially before bedtime, before they need to do homework. We see a lot of children fall asleep in swings. That's because that slow calming movement is very calming to their vestibular system. Sitting in a rocking chair, I put rocking chairs in every classroom. That is very calming, especially as the child gets a little bit older and they're needing to like learn their spelling words. You're going to want them to do a little bit of rocking. If you have a front porch swing, you need to be working on your spelling test over on the front porch swing. If they're having a meltdown, that may be a place to go. Is like doing that rocking back and forth is really calming. Let's see, some other ones like crashing is a big one. If I see a child that's especially in a classroom or at home, they're doing something like climbing where they shouldn't be climbing, then I will put a big old pile of pillows and couch cushions in the corner, and then we're going to run and crash into it. And that's going to do the same thing with like the heavy work. It's going to be putting pressure on their joints, which I don't think I mentioned that earlier. That's why that works so well, is that you're putting pressure on their joints across their body, which sends chemicals to their brain to help them relax. So that's why the heavy work is working. It's pretty much the same concept as a weighted blanket. The weighted blanket is doing the exact same thing. It's putting pressure on their joints, and that's what helps calm them. And if you're in the car and you can't do that, give them something crunchy. That's my daughter eating an apple. She was really, really young, and I just gave her a whole apple because the same thing, a crunchy apple is putting lots of pressure on the joints in your jaw. So you can do that, giving them a beef jerky, something that like a stale bagel, something that's really, really crunchy or chewy, that if you can't get somewhere where you're going to be able to move and move like you're on an airplane, thinking ahead and giving them things that will help with that, like the crunchiness is going to be beneficial. Or the deep pressure, like the vibrating toothbrushes is also another favorite hack that I have, that I will keep those like in my purse, or like I'll recommend them to families that if I have a child that's chewing on everything and like the kid I was talking about earlier, like chews on wood and drywall, vibrating toothbrush actually helped him a lot. Just adding a little bit more pressure. What is our time? How much are we? I meant to ask you that, Lynette.
Can you hear me?
Yeah.
We usually just do an hour. So, I see people are still on. Since it's in the evening, people might have a little bit more time. You're kind of getting into the stuff that I think a lot of us have older kids. So if you're able to keep going, have at it. If anyone needs
Okay.
to leave, you'll get the replay of it later.
Okay. Okay. Yeah, you just cut me off. I'll go through this, and then I'll give you all the slides so you can look a little bit more in detail. I try to include links and things so that way at a later time you can always come back and watch videos of things we talked about. But language delays is another area that I do get more questions about as children get older. Language is something I always say, like, takes the back seat in their development for a while, that their body is typically just wanting to be on the go. They're just wanting to move, 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 move. And so their focus is just getting that energy level out. So sometimes we'll see there is a little bit of a language delay. I don't typically see it lasting for so long. it may continue to needing early intervention in school age just to focus on some articulation. But usually, if we can see where the energy level is, and that typically does kind of go back to all these other things, the screen time, are they getting enough sleep? Is their body trying to tell you that they need more pressure, that they need to be doing some of these heavy work activities? A lot of the times that can really, really help with regulating their brain to where they're in like a good area to be learning language. So another area, oh, I did put that on here. Good. My next slide is we do see physical features with children that have substance exposure that they do have smaller ear canals, which if that is the case, then you're probably going to see more wax buildup and again, more chronic ear infections. If we do have chronic ear infections, then you are going to have a language delay. If the child is not hearing 100% clearly all the time, 24/7, then there is always going to be a little bit of a language delay just because they're not hearing the way they should be. So allergies is another one. If you, especially like in East Tennessee, we have the worst like pollen here, and we have a lot of allergies going on. If you have a kid that is constantly draining, they're sneezy, they're like just mucusy, they're constantly draining mucus out of their nose, then you can probably guess that there's probably fluid in their ear too that's kind of coming and moving in and out, which is again going to be causing some disruption to what they're hearing. So that all of that to be said, that can lead to some language delays. I also see like when I'm, if I'm working with a parent that is in recovery, that can also be a challenge and to a barrier to their language development. So they may be really focusing on their recovery and staying sober, and that can limit that back and forth interaction with a child. So there's lots of components there, but yes, it is common to have expressive language delays. Very, very common. Expressive and receptive language are two different things. Expressive is like what you're able to vocalize, what you're able to say, what you're able to express by like pointing. Receptive is what you're able to understand. So when I say it's time for dinner, are you able to look at me, understand what I said, and then go to the table? Receptive comes before expressive. So if you have a receptive delay, then you're definitely going to need to have some speech therapy. Pathways.org is something that I recommend. I think they do a great job with all areas of development. They'll share like their communication and motor and social and play and all those things. I put the link at the end of the slideshow, so that way you have that. But they share like the difference of expressive and receptive language and what to look for. So if you are telling a child go get the ball or go over there, are they able to do it without you using gestures, or are they only looking at you using gestures to do something? So again, that kind of goes back to, are we using pictures to kind of help with communication? Regardless, the picture cards are really, really helpful, or using visual schedules, whether you're in a classroom or you're at home, that can be really helpful too. I don't think I did a good job of highlighting this, but there is a video down here about language and the brain. It probably looks like I'm just trying to use a caption for that, but that there is a video right here that you can click on, and it goes more into detail about that. The motor delays too with high muscle tone. You see it more prominent in early childhood, the stiffness, the high muscle tone. I do see a lot of asymmetrical limb movement. And what that means is that one side of the body might be a little bit weaker than the other side. That can be challenging because if you have a child very, very, very early young that is only preferring to use one side of their body, they are not stimulating both sides of their brain. That is going to cause issues later on when they need to you need to be able to cross parts of your brain. So if an easy way you can see this is if you hand somebody something on this side and they reach don't reach across their body to get it, if they have something in this other hand, you can tell that they are not crossing midline. So crossing midline is like pretending there is a line in the very, very middle of your body. If you cannot cross and grab something, or if you're a child that is what we call it hitched crawling, so it's a child that only uses one leg properly and the other one kind of like uses as like an anchor, or pushing them along. A child that's like bum scooting, so they only want to scoot around on their bottom, or have delays with like pulling up. It seems like, okay, yeah, we're not talking about infants like my child is like 10, but all those things are correlated. That if you have a child that did not do a lot of like crawling properly, or even torticollis, if they had torticollis issues, or they had an early preference of their hand, like you started seeing them do everything with their left hand very, very early, those are red flags that there are some asymmetrical things of their brain development, which is very common with high muscle tone. So I may have a child that early on, like maybe the left side of their body was really stiff and they kept one leg tucked in a lot, so they use the right side of their body. That is going to affect them later on when they're learning to read, because we need to use both of our sides symmetrically and being able to cross midline, because when you're learning to read, you're going from left to right and your whole brain is having to use both sides to communicate with each other. So we do see children that have high muscle tone, and are having a preferred side over the other, or have torticollis, or if you have a child that you're like, yeah, they did do hitched crawling, and you're now in elementary school and you're struggling with reading, these things are related. So that is something that you can talk to an OT about, specifically one who knows a lot about I was just talking about this earlier today, retained reflexes, that knows a lot about that. Your Kids Table is a really great resource. I think I put that at the end too, that can help with all those things. If you don't have a good OT, you can go on there and they have like webinars. She's a fantastic OT that shares a lot of information. But I say all of that because all of those things very, very, very early on get dismissed a lot, like having their hands fisted, having their little toes. I put that picture on here because I had a little kid that always clenched his toes, even when he was learning to walk. And you're not very stable when you're constantly clenched, and he was falling all the time, or only using one side that's like more clenched than the other. So all of these things are related. So it's not, I know I talk a lot about infancy in my presentation, but all of these things are correlated later on. So if you see those things and you're like, wow, my child is still really struggling with his handwriting, really struggling with, reading, these are things that could be very much correlated to stuff that happened in infancy. So I would suggest looking into like an OT to help with those things. Even like being able to hold a pencil, a crayon, anything like that. It goes back to that sensory system. Are they able to know the pressure of what they're doing with the pencil without like bearing down too hard and it breaking? Or are they like having a hard time even gripping it at all? So those are some things to be looking out for. I think this slide is more specifically for like infants. I will also get on my soapbox about never picking up an infant from behind, never picking up anybody from behind. That startles them. It's a lot of fear is put into their little nervous system. So positioning them in places like, if you're going to be picking up an infant, having them practice rolling over, we see a lot of delayed motor development in early childhood with our kiddos with NAS. It talks a lot about baby wearing, and we see a lot of back arching, which again is kind of goes back to that muscle stiffness and the retained reflexes. Okay, I think we're getting to the end here. So because of the experience that I've personally had working with biological parents, there is a lot of taboo about talking about addiction, talking about recovery. So I do share information about that because there was not a person that a mother that I ever worked with that did not have a co-occurring disorder that was in recovery, that they did not have depression, anxiety, extreme trauma, neglect from their own childhood, abuse, like, schizophrenia. There's pretty much very, very, very like high rate of co-occurring disorders with a mental health disorder of addiction. And addiction is a mental health disorder. So we are talking about NAS, which is completely preventable by not using substances when you are pregnant. However, I do always like to talk about adulthood and previous trauma that a mother has had. So, being non-judgmental and taking that approach when we're supporting families, knowing information. That's why I share things at the beginning about, the medically assisted treatments for opioid addiction. Addiction is a disease, and so it is horrible, and nobody ever wants to wake up and say I want to be an addict today, but it is a mental health disorder. And then the same conversation with that is that, I do see online a lot of people, which I will always comment and correct, is that children are not born addicted. So that is something as well that we don't say that this child is substance addicted or they're addicted to drugs or the term from the 90s of crack baby. Those are things that a child is not born addicted. Addiction is a mental health disorder. They're born going through withdrawal from substances. So that's something that they're not choosing to do. So early identification, early intervention are very crucial for the whole family, for wraparound services. I'm very thankful that we have so many services here in Tennessee that are able to do wraparound services for families. We have early intervention is available in every single state. And I put that link on here as well. Of course, Generation O is the very first one that I always suggest to people because it really is such an amazing organization that is so helpful. I mean, the website with all of the articles and resources, I mean, in one place, like, gosh, would have saved me so much time many, many years ago when I was starting out to have this information, or for families to have this information in one place to like, this is the type of diaper cream that would be really helpful for you, or understanding the GI, disturbances that a lot of these children have. But some other resources that I have on here, Aim High is something that I'm really passionate about too, about infant and early childhood mental health. They are a great organization that is across the nation as well. Pathways.org, understood.org. If you have a child that is like over the age of 3, I highly recommend you become very familiar with understood.org. There's even information on there about what the difference between a 504 and an IEP is, which is really helpful because not all children will qualify for an IEP, which is an individual education plan, that they may qualify for a 504 to get support in the school. So that, I mean, I couldn't even fit all the resources on here for understood.org. There's even like apps that you can get that talk about everything about ADHD and executive functioning and a lot of the things that we see correlated with NAS. But a lot of the other things on here are things that you can find in your state too. Nurturing Parenting is a national program that offer like parenting program for everyone, for people that are in recovery, for people that are incarcerated, for first-time parents, teen parents. There's local support groups and there's national support groups for NAS, which I've seen are linked on the Generation O website too. Healthy Families is also a national organization that is in every state. I'm pretty sure Parents as Teachers is also a national one that's available everywhere. And also the trust-based relational intervention, what we call TBRI, is something I would also highly recommend if you are a caregiver or you're working with children that have been substance exposed, it talks a lot about trauma and how it affects the brain when we're working with children, and the connection and the importance of their relationship with a child and a caregiver. So these are really great resources and the ones that I highly recommend. I forgot to add on here that yourkidstable.com. I will add that before I send it over to you, Lynette. But that's also a fantastic resource. But also, I put my email address on here. So if you have questions, it might take me a minute to get with you. Just be patient because I'm out in the field a lot, and I'm in schools and people's homes. So not on my computer a lot, but email me if you have questions. I have a million resources. I'm going to send Lynette a lot of stuff that you guys are more than welcome to share and have. And I also created my own little Facebook page because during COVID, yeah, I needed some outlets, ways to share information with people. But if you need anything or have questions, feel free to reach out to me. But I am sorry I went over, but I am so happy that I was able to share information with you all, and I look forward to working more with Generation O and helping support everyone however I can.
Tiffany, that was so amazing. I mean, you are really a wealth of knowledge, and I know that you've acquired so much of it just with your own research. And, there's no one out teaching this stuff. So, with the lived experience as an educator and just figuring it all out, amazing, amazing.
Oh,
Thank you
well,
so
thank
much.
you.
The fact that we're going to be able to put this on our website and share the slides, that's going to help a lot of people who couldn't tune in tonight.
Yeah,
Um, yeah, so this was as good as we had hoped. We were all so excited. I know some people couldn't make it, but they're looking for the replay.
yeah.
And we're so glad that we found you and that you believe in us as much as we believe in you.
I'm just so happy. Like yeah, I'm just so happy for Generation O's out there. Really, every time I look at the website, I really am just like, oh my gosh, they really have everything. There's a whole article about stuff that I talk about. So I just thank you all so much of everything that you all do. It's a lot, and you all are making a very big difference in families' lives and kids' lives.
Well, if everyone else is if no one has any questions, I don't think there's anything major in the chat. Um, we are going to skip Insights Live for the month of January because we don't expect people on January 1 to be ready to listen to a webinar, but we'll continue in February. But thank you again for being here, for doing this for us, and thank everyone for attending. And for those who watched it online, we're so glad that you could get the information as well. So I will close this out and say goodbye to everyone. Thank you.
Bye. Thank you.
Yeah.